Welcome, everyone, to the SETS mini forum on data extraction, organized by the Co-Data Center of Excellence in Data for Society at the University of Arizona, SETS. I would like to express my appreciation to Meg Fox, the center's founding director, for her endless and continuous guidance and support in turning my thought into a presentation and making all this possible today. My name is Felix Anyiam, presently working as the research and data scientist for the Center for Health and Development, University of Port Harcourt, Nigeria. I am also an initial lead of the early career data professionals of the co-data community. Today, I will be presenting in the mini forum my idea on the topic, data flows and information sharing. Why is COVID-19 different? As of June 9, 2020, the outbreak of the novel coronavirus has killed over 400,000 persons with at least 7 million cases globally. In Nigeria, infectious cases exceed 12,000 with over 300 deaths recorded. Nigeria's reaction has varied among stakeholders with conflicting reports and priorities. For example, there has been disagreement about preventable mechanisms, such as whether to lock down or not to lock down, whether physical distancing is required and how to do it, what hygiene practices should be used, and by whom, and herd immunity issues. Also, case management procedures have varied between agencies and providers, with some advocating empirical studies and others promoting an experimental approach, and experts disagreeing whether a drug remedy is effective or not. Other contradictory and confusing messages include the controversy over the origin of the virus and other conspiracy theories, and the basic pathophysiology of the disease and how it has evolved. Of course, these are complicated by economic issues, the distribution of welfare packages, provision of loans or palliatives, and the need for seed capital to keep businesses open. All of these issues could be improved if we only pay attention and review our data collection and utilization strategies. With the COVID-19 pandemic, Nigeria has paid little attention to the adequate collection and utilization of health data, and the state has ignored the important role that data plays in informed decision-making. Instead, Nigeria is borrowing intervention procedures from social media, international news media, and politicians. So we ask the question, why is COVID-19 different? Nigeria is the most populous country in Africa with a population of over 200 million. It is located in West Africa in the Gulf of Guinea, spread across 36 states and the Federal Capital Territory. The Nigerian health sector ecosystem includes public, private, non-governmental organizations, community-based organizations, faith-based organizations, and traditional healthcare providers. The public health service is organized into primary, secondary, and tertiary levels. All three levels of healthcare delivery systems are accountable for ensuring equitable healthcare service delivery. National health policy assigns responsibility for primary to the local governments, secondary healthcare to state governments, and tertiary healthcare to the federal government. Nigeria has a national guideline for coping epidemics and pandemics based on WHO guidelines, called the Technical Guidelines for Integrated Disease Surveillance and Response, IDSR, that guides its operation The goal of IDSRO is to improve the ability of primary health facilities, which is the grassroots facility and the entry point to other tiers of the healthcare system in Nigeria, to collect data from disease detection, identification of conditions with high levels of death, illness, and disability in the communities. But for COVID-19, Nigeria is not using the IDSRO, and it is also ignoring its focus on the primary health facilities in the fight against COVID-19. Disease surveillance focuses on the ongoing systematic collection, analysis, and interpretation of health data. In other words, it is difficult to talk about surveillance without data. The IDSRO guidelines task the primary healthcare level, the local government area, or LGA to detect and respond to disease and disability at the local level, and to improve the health and well-being of communities. Effective IDSRO begins with effective LGA disease monitoring and control mechanism, with clinicians actively involved. From the chart, you can see that the community or LGA level is the focus of integrating surveillance functions. Usually, LGA health facilities are equipped to test, collect specimens, investigate, analyze, and share results. This is where surveillance and data reporting begins and flow upwards to the national. As you can see, Nigeria already has the foundation to support the effective management of communicable disease. But in the case of COVID-19, the LGA is passive in the fight, as they have not been adequately equipped with the tools needed to act. According to the national statistics, there are 17,068 health facilities in Nigeria, and 44% of them are local government area primary care facilities. However, only the state level or secondary, federal level or tertiary facilities are engaged in COVID-19 data collection and reporting. In other words, less than 10% of Nigerians' health facilities are managing 100% of Nigerians' COVID-19 data. As a result, the data they are collecting and sharing is insufficient to study the disease epidemiology. Several studies across Nigeria have shown poor knowledge and attitude towards IDSRO strategy usage and implementation amongst health workers. These studies should be pointers towards healthcare strengthening at the community and local government area levels. IDSRO is a bottom-up approach, meaning the community and the local government area level should be the pivotal. Our studies have also shown increased implementation of IDSRO strategy after training. Nigeria's news media on community spread shouldn't be media-worthy if the IDSRO strategy is properly implemented. We sound like the disease is just arriving at the community level and we are trying to contain it. Our approach from the start deviates from our national guideline. Clinicians at the LGA level remain indispensable in providing community data for effective clinical judgment for COVID-19. To enable us effectively fight this pandemic, everyone should have a clear-cut role. The primary level, which is the LGA, should be involved in providing adequate data through contact tracing, screening, testing, surveillance, and health promotion. The secondary level should provide further screening, testing, surveillance, and managing our isolation centers. And the tertiary level should provide leadership, retrain health workers, and review primary and secondary data management and reporting cases. Their researchers have the responsibility of developing new techniques, drugs, and interventions based on robust data generated from these tiers of the healthcare system. Private sector laboratories should also be strengthened to provide screening and testing. This way, contact tracing, screening, surveillance, and health promotion is at the grassroots level and everyone can take responsibility. Right now, if it's going well in the fight against COVID-19, the national level is applauded. And if it's going poorly, they take the fall. This just shows that the other tiers of the health system are not well represented and strengthened enough to be more active than they are now, as our present approach is unsustainable and should be reviewed. With the COVID-19 pandemic, we have noticed a sudden isolation from the usual network of global healthcare partners. During the Ebola incident in Nigeria, the government-led response included many different international organizations. For other diseases, Nigeria's healthcare management system is not isolated. It works in cooperation with the international partners, private, non-governmental organizations, community-based organizations, faith-based organizations, and even the traditional healthcare providers. With COVID-19, there is no clear cooperative process, and the normal interaction with community experts is not working. In addition, the private sector, which represents 43% of Nigeria's health facilities, has not been mobilized in the fight against COVID. Because of this lack of collaboration, everyone is working in isolation. No available standard treatment guidelines are being followed, as each health facility uses the remedy that suits them. Even when guidelines are followed, data on the methodology and approach is not made available. Rivers State, my state of residence, with a population of over 8 million people, has only 2 isolation and treatment centers, 1 secondary and 1 tertiary, and they work in silos, isolated from each other. In my city, Port Harcourt, we hear stories of prayer healing, with patients fatally infecting their pastors, patients being treated in hotels, and unauthorized and unequipped private hospitals. At the community level, people hide their relatives showing COVID-19 symptoms until they die at home or become too sick to be treated. These cases are not reported to the community health authorities. This is extremely unfortunate because all these random treatments are avenues for data generation, but instead they are lost and a vacuum of data, information, and knowledge continue to be created. COVID-19 has shown that we have a weak emergency response structure and that we were not prepared. COVID-19 data collected and made available to the public by the Nigerian Center for Disease Control, the NCDC, reports only the number of cases, the number of deaths, and the number of recoveries. These disparate data cannot drive actionable research. This pandemic demonstrates the need for Nigeria to have an open national data repository because it is too big for one national agency, the NCDC, to be the sole custodian of healthcare data. Open data repositories store and share robust data over time and across regions, providing more insight into the nature of the disease and clarity for clinicians, researchers, and data practitioners when modeling and even treatment modalities. Modeling a comprehensive data set can tell us things about the rate of spread in specific communities, the rate of spread in a particular ethnicity, the rate of spread in particular socio-demographic and socio-economic characteristics, the rate of spread in the coming months, and can also give us estimated mortality rate and an estimate survivability rate or recovery rate based on location or other captured variables. In the era of big data, Nigeria has very little data about COVID-19 and the coronavirus that causes it. The disparate data creates a serious knowledge gap. Existing data falls short of usability to generate actionable research for policy implementation. Vital information such as location, income, gender, age, other metadata that help explain how individuals might be getting the virus and how they might be best treated is lacking. Robust data provides the best and cheapest approach to understanding any disease condition in the 21st century, as we can learn more from our own generated data than any information from the media and other countries. In conclusion, our world is actively changing and our local healthcare system needs to change. COVID-19 is different because the data experts, the emergency responders, the local healthcare professionals, university lecturers, data scientists, international partners are not involved in the response. The challenges to adequate health information systems include disease monitoring and analysis of health indicators. We're experiencing a lack of clarity with regard to data submission and responsibilities and inadequate quality control measures. We need to begin exploring new data options in the fight against COVID. There should be adequate and effective staff training in data management, interpretation, and use at all levels of the healthcare in order to provide rich metadata for effective decision-making in the fight against COVID-19. Thank you and stay safe.